of laryngology pattern questions on the topic pediatric stridor. The first question. So how do we solve the question now? I will teach you how to solve the questions, which are 2 to 4 lines big. And the first of all, you have to read the last line and what the question is asking. It's asking the most appropriate next step in management. Now, now you know the next step of management. Now we'll read the questions. 6-year-old, previously healthy, full-term infant is brought to you in clinic for the noisy breathing that began at 2 weeks ago. Noisy noise is purely inspiratory and worse when she is spine, feeding, or agitated. She is gaining weight appropriately along the 50 percentile, and epidurial shows an omega-shaped epiglottitis, a prominent prolapse arytenoid cartilages. So now we read all the options. Do we have to immediate perform the microlaryngoscopy and bryngoscopy? MLB, do we have to check the 24-hour pH probe study? Do we have to reassure the patient's parents and schedule the follow-up after 3 months? Do we need to initiate a PPI? And do we need to go for the CT with the contrast? The answer is to reassure and schedule the follow-up in 3 months. Why? This is a classical presentation of uncomplicated laryngomalacia. The key positive indicators are the age of onset, which is 3 months, 6 weeks, and, and the patient is characteristic of the sound, the inspiratory stridor, and excellent weight gain, appropriate according to diet. And epidurial finding also confirmed that it was laryngomalacia. So, in the absence of concerning features such as apnea, the failure to thrive in cyanosis, and reassurance is the standard of care. Microlaryngoscopy and bronchoscopy is a gold standard, but is not indicated without the red flags. And reflex therapy, such as PPI, is often used empirically, but is not the most appropriate next step for an asymptomatic child. And CT with contrast is not indicated. Now, next question. So they're also asking for what is the first line of management. You are called to ER with a 3-year-old with the acute stridor and barking cough over the last 12 hours. On examination, child is alert but has mild intercostal recessions and respiratory rate is 35. Oxygen saturation is 96 on room air. What is the first line of management? It means the patient is most likely stable. So, patient is in a stridor but in a barking cough, but on examination, patient is most likely stable. There was mild intercostal recessions. Now we have option A. So should we go for nebulized adrenaline? Should we secure the airway with ETT? Should we go for the imaging? Should we go for the oral intramuscular DEXA, or should we go for the endoscopy in the ER? So as the patient is stable, we should go for some. It means that should we give him the meds, should we go for the imaging, or should we go for the management? As the patient is not any, as the patient is clinically stable, so we cannot go for the intubation. And the patient is in mild distress. So as the patient is not that completely stable, it has some intercostal recession and high respiratory rate. So it means that he is in mild distress. So we need to treat him. For the treatment, we have what option? And the other option, if the patient was completely stable, then we would have gone for the imaging. And now let's discuss. So we have to treat it. Why? Because he is in the moderate group. As we have that all children with a croup and increased worker breathing should receive glucocorticoids. Steroids are the first line for reducing an inflammation, as nebulized adrenaline is for moderate to severe distress but provides only transient relief. Intubation for impending respiratory failure, imaging risks upsetting the child and worsening the obstruction. And endoscopy is contraindicated in acute infectious croup due to risk of complete airway loss. Next questions we have, what are they asking? Which of the following is the most likely diagnosis and the most critical initial investigation? So, 2-month-old ex-premature infant born at 28 weeks with a history of prolonged mechanical ventilation, present with a biphasic stridor, and recurrent cyanotic spells during feeding. Which of the following is the most likely diagnosis? It means if the stridor is biphasic, it must be in the subglottic rib. And the patient has also endorsed factors of. So what can cause the biphasic? And they're asking for the most likely diagnosis and initial investigation. So laryngomalacia and epidurial. No, laryngomalacia doesn't give you the biphasic stridor. Vocal cord palsy and MRI brain. The vocal cord palsy gives the hoarseness and give you the stridor. Subglottic hemangioma and initiation of the propranolol. This could be one. And the other is subglottic stenosis and MLB in bronchoscopy. This one also gives you the biphasic stridor, as the patient also has a prolonged mechanical ventilation. And tracheoesophageal fistula and barium swallow, which is for if the patient has recurrent cyanotic spells during feeding. If the patient would have the cough, we would think about it. So the answer is direct acquired subglottic stenosis and will be in bronchoscopy. Why? The history of prematurity and prolonged intubation is the classic risk factor for the acquired subglottic stenosis. Biphasic stridor and cyanotic spells are severe symptoms. MLB is the gold standard for the diagnosis and evaluation. As we have discussed, laryngomalacia causes inspiratory stridor, not biphasic. While the other options are possible, the history points directly to the subglottic stenosis and most likely cause, and MLB is the most critical test to confirm and rule out the other lesions. Next up, we have what is the primary advantages of this technique and diagnostic accuracy. So we have during MLB, they found out for a stridor in a 6-month-old baby, the anesthetist was using the spontaneous ventilation technique and sevoflurane. So why are they using spontaneous ventilation and sevoflurane? It completely eliminates the risk of laryngospasm. It allows for the assessment of dynamic airway collapse. It provides a longer, more stable surgical time. It eliminates the need for topical lidocaine. It is the only technique that allows for the jet ventilation. For me, the most likely answer would be it allows for the jet ventilation. So the answer is it allows for the assessment of the dynamic airway collapse. So why? The text explicitly states that the spontaneous respiration is essential to diagnose the dynamic conditions such as laryngomalacia and tracheomalacia. Paralysis would explain the airway and mask these pathologies. While it may reduce the laryngospasm risk, that is not the primary reason. It is often provides less stable time than paralyzed techniques. Topical lidocaine is still often used. Jet ventilation is a different technique. So they are saying that spontaneous respiration is essential because to diagnose the dynamic conditions such as laryngomalacia and tracheomalacia, which are masked during the paralysis of the anesthesia. Next question they're asking, what is the single most important action to avoid? 15-month-old toddler present to ER with a 2-hour history of acute onset of stridor, drooling, and high fever. The child is sitting upright and leaning forward. So what to avoid in these conditions? You have to diagnose this condition. It is characteristic of upper airway glotitis, acute epiglottitis. So there are option number A, administration of supplemental oxygen via a nasal cannula, obtaining IV access, performing lateral soft tissue neck X-ray, laying the child flat to examine the oropharynx, and administration the IV dexamethason. Mommy, I would like to go for the option D, as this would compromise supraglottitis. Next. So the answer is laying the child flat and examine the oropharynx. The presentation is classic for epiglottitis. Manipulating the child, such as laying them flat, can cause a complete airway obstruction. By dislodging the inflamed epiglottitis, all other actions are appropriate. Oxygen, IV access, antibiotics, fluids, X-ray, if done portably with minimal disturbance, and steroids are part of the management, but only after the airway is secure in controlled setting. So this question is asking, what is the best explanation for this paradoxical find? So the question is, the parents of a child with a mild laryngomalacia reports that the stridor has suddenly gone quiet. Laryngomalacia and the stridor gone quiet. The child is now lethargic, has significantly increased work of breathing, deep recessions, but no audible noise. So what suddenly happened to this child? Option, the laryngomalacia has spontaneously resolved. Not likely, very unlikely. The child has developed a superimposed bacterial tracheitis. The patient would have had the fever. The airway obstruction has worsened, reducing the airflow to the level where sound can no longer be generated effectively. Pathology has moved from supraglottitis to subglottitis, and the child has developed a vocal cord palsy. It's very confusing, all of them. Let's see that. The airway obstruction has worsened, reducing the airflow to a level where the sound can no longer be generated effectively. Why? This tests the application of Euclid's law and Bernoulli's principle. As the radius of the airway narrows critically, airflow becomes insufficient to generate the turbulence, and that causes the sound of the stridor. The disappearance of the sound is therefore ominous sign of the severe obstruction, not improving. The other options are possibly, but are not the best or most direct explanation of the specific paradoxical finding. So next question we have, which of the following imaging studies is the most sensitive for identifying radiolucent foreign bodies in bronchus of 2-year-old? A. Epi and lateral X-ray? No, very unlikely. Inspiratory chest X-ray? Unlikely. Next, CT with contrast and airway fluoroscopy and barium swallow. For the airway, there are two options. I would like to go for the next CT, but it is only for the neck. So the most likely would be the D, airway fluoroscopy. Though the answer is the inspiratory and expiratory chest X-rays. For radiolucent foreign bodies causing ball valve effect, the affected lung will remain hyperinflated on expiratory film due to the air trapping, while the normal lung will deflect. This is a classical finding, more sensitive than the single AP film. So inspiratory expiratory chest X-rays. CT is definitive but radiation burden and is not a first line, and fluoroscopy can show mediastinal shift but is less specific. Barium swallow is for esophageal foreign bodies. Next question we have, what are they asking? What is this procedure called? They are asking for the name of the procedure. A neonate is diagnosed antenatally with a large cervical teratoma causing significant neck extension and polyhydramnios, and the multidisciplinary team recommends the procedure to secure the airway during the delivery. It's exit, most likely. Exit is acute to interpartment treatment procedure, neonatal tracheostomy, fetoscopic airway laser ablation, C-section under GA, laryngoscopy immediate upon delivery. Yes, it's A. The exit procedure is specifically designed to secure the fetal airway via the intubation and bronchoscopy or tracheostomy, while the fetus is still in uteroplacental circulation, preventing catastrophic airway obstruction at the moment of delivery. A neonatal tracheostomy would be performed during an exit procedure. The other option do not describe the specific technique of operating and on placental zone. Next question we have, they're asking, in the evaluation of the Stridor child, which of the following findings is most strongly associated with fixed extrathoracic airway obstruction on flow volume loop analysis? Flattening of the inspiratory loop is most likely for the inspiratory causes, flattening of the expiratory for the expiratory causes. They are asking for the extrathoracic airway, flattening of the both inspiratory and expiratory loops, and sawtooth pattern on both loops, and isolated reduction in peak expiratory. Most likely I would go for the C. Let's check. C, flattening the both inspiratory and expiratory loop. Because we have read that the fixed obstruction is causing the biphasic, so biphasic are critical for the subglottic stenosis, does not change with the phase of the expiration. It limits the airflow equally during the inspiration and expiration, resulting in a flattened box-shaped flow volume loop. A variable extrathoracic obstruction flattens only the inspiratory loop. A variable interthoracic obstruction flattens only the expiratory loop. Next and last question we have, they're asking, what is the most important reason to perform MLB in this scenario? Why are they performing? A 4-year-old history of recurrent croup is scheduled for an MLB. Parents ask why this invasive test is necessary when there is still always improves with the steroids. So we have read that the recurrent croup, it means the patient might have some congenital airway disease, subglottitis. To administer contribution steroids to the subglottis and to rule out the fixed anatomical lesion predisposing the child to the recurrent croup. C2 diagnosis of the croup, the steroid do not work for that condition. To perform diagnostic bronchoalveolar lavage to assess the gastroesophageal reflux. So I would go for the B. So recurrent croup is a red flag, while wild croup is common. Episodes that are frequently severe and recurrent occur outside the typical age range should prompt an investigation for undergoing fixed anatomical narrowing such as subglottic stenosis, hemangioma that becomes symptomatic with even minor edema. MLB is the only way to definitively visualize and diagnose these lesions. The other options are not indicated for MLB. Thank you. And